All right, good morning. How is everyone doing? If you're here, could somebody or a couple of people type in the chat just so I know that folks are in the room? All right, wonderful. Good morning, everyone. I'm actually calling in this morning from Vegas. I'm here for another conference, but Cecilia and Alexis were so kind to invite me to speak a little bit about our work in Medicaid. But honestly, a lot of how I was thinking about this conversation and the slides that I'm going to be presenting is about making it really engaging. So, for the folks in the room, I know a lot of you at the community health centers have seen before the unwinding and are probably thinking and bracing yourself for some of the changes of HR1. So I'm going to be walking through some of the things that we've learned as a company, focused very squarely on helping enrollees understand their eligibility, enroll, renew, take coverage actions, and also transition off of Medicaid into other programs. And maybe just some helpful context as I'm sharing my screen is sharing that I actually got and started my career in two FQHCs, one in Vegas and one in Oklahoma. So if anyone is from Vegas or Oklahoma, shout out if you want to put it in the chat. But I'm just going to start by talking very briefly about our company and then sharing some learnings that we had from the unwinding. So, as I mentioned earlier, my background, I've worked on the FQ side, helping with access and affordability. I'm sure there's folks on this call that have served in that same role, helping folks navigate coverage, maybe focusing on more of the sliding fee scale side. But one of the things that I saw when I was doing that work was just how challenging it is to clearly understand what you're supposed to do, understanding the steps that you need to take to do it, and even knowing if you've done it correctly. So when I think about the lessons we learned during the unwinding, there were sort of, I'd say, five main takeaways that if you look back to 2020 through 2023, if you're familiar with this, during the public health emergency, Medicaid renewals were frozen. And so what that meant is the federal government and states were not checking as folks were both enrolling, but also maybe coming up for their normal renewal cycle. They didn't have to do it until the end of the unwinding. And at the end of the unwinding, that's where we saw scores of people, millions of people being disenrolled from Medicaid for not understanding, again, the steps that they needed to take to renew or action around their coverage. The ways that we bucket that as a company is around awareness, understanding, and action. This is actually from a study out of NAC, and it reflects to the things that we saw on the ground, which was that a very large number of folks, 77%, weren't sure when they needed to take an action related to their coverage. 85% didn't understand how to read their coverage notices. 70% struggled with state websites, and almost 50% had lost passwords at various points in having their coverage. And then even when it comes to taking action, so sitting downstream of if you knew what you were supposed to do and understood how to do it, 63% of people were making multiple attempts to renew, and 55% of people experienced long call wait times connecting to the state or connecting to the county. I'm curious for anybody in the chat if this reflects some of the experiences that your teams have had or you've seen your patients face when they think and when they have run into their renewal periods, or maybe you've sat downstream of folks that have now become uninsured. Feel free to share some of those thoughts in the chat because I, of course, very curious if some of the data that we're sharing here is resonating with some of the experiences that you might have felt. And then, of course, let's talk about some of the new program requirements. So, of course, everybody, I'm sure, is aware of some of the changes from OB3/HR1 related to both Medicaid and ACA. So I'm going to touch on on many of those different variations throughout and also talk about when they go into effect. Just so as your organizations are thinking about what you may expect to see patients struggling with, and what they might need your support on, here are just 6 buckets of things that are in the new HR1 rules. The first and probably the most discussed is, of course, work requirements. Now, work requirements is not addressed towards every single type of Medicaid enrollee. It's for Medicaid expansion populations and able-bodied adults that are around 138% or above of the federal poverty limit. So the Medicaid expansion population, if you're familiar with that terminology, are after the ACA, the Obama administration worked to expand Medicaid to a wider group of people, and about 40 states chose to expand Medicaid. Now, both before you enroll and over the course of your coverage, any enrollee that sits in this category, so you'll see there both pre and post enrollment, do need to verify that they are working or participating in community engagement. A lot of states that we work in and work with are doing work already to check that information upstream. So, checking various data sources, whether it's the Department of Labor, DMV, verification records around immigration status, the new higher wage database, et cetera. And there are, of course, some exemptions that people can apply for when they're coming up for verifying that they're working or participating in community engagement. There are also notices and periods of noncompliance that gives some allowances to enrollees, but this is definitely going to be a period of a lot of change. And the reason I say that is many states have not yet decided how they are going to be doing work requirements and community engagement and validating it. States haven't decided what requires documentation and what requires self-attestation. Unless you are in a state like Georgia that has already had work requirements for 2 years, a lot of this will be new things that your state is rolling out and new things that the state's technology is rolling out. So we expect that there may be some forms of errors or maybe some challenges associated with doing this accurately. A lot of it comes down to how states too will define certain exemptions. I want to take the exemption example of medically frail, if you can see it here on this list. Medically frail can mean a lot of different things depending on what the state defines it as. In some states, medically frail counts as certain types of behavioral health conditions. In others, medically frail is a much stricter definition of chronic care and chronic illness. So those are things that, as the state that you're in is rolling things out, certainly to pay attention to. Another, of course, that you've likely seen or heard about is citizenship verification and how states are checking those. So there's certain aspects of income, which we'll get to later, but to focus on how both the federal government and states are verifying citizenship is, of course, using data sources, but where those data sources are not able to be verified, ensuring and mandating actually as the beginning of this year that beginning of next year, sorry, that states can lose their funding if patients don't go through that in a consistent way and do not provide their information. I'm really curious for anyone again in the chat if you're worried about some of these things on the non-citizen side. As a company that serves folks in states like California and New York, we're already seeing certain activity related to people disenrolling, even if they have an immigrant in their household. So they may not themselves be a non-citizen, but just folks that are in their household. To touch on a couple of others as well, 6-month redetermination is probably a thing that your teams have also been paying attention to. So this means, again, for that expansion population that faces work requirements that we mentioned earlier, these folks as well, now instead of once a year, now are going to have to renew their Medicaid every 6 months. And this is a lot of folks. As you can see that number, about 23 million people are covered through the expansion program. There are exemptions. Not everyone will have to do the 6-month redetermination. One common group that will not have to do this is, of course, women that are pregnant or even postpartum. But this is still another group that before they were more stably covered if for a year. and now we'll need to renew every 6 months. Another one, just to sort of holistically round out that this is not just Medicaid, but also ACA that is affected. Open enrollment, which under the prior administration was a lot more open, is now being very strictly limited to November, so coming up soon, and December 15th, so a very short period. Before, there were more special enrollment periods, so if people were eligible, they were more easily able to enroll in the ACA, but that is no longer the case now. It has to be from a qualifying life event, so something like getting laid off. And this is very new and something that a lot of plans that we talk to, a lot of providers that we talk to are very nervous about. Now, exchanges have to verify at least 75% of enrollments of people coming through on the ACA side. This was not something before that most exchanges were doing. They were just allowing people, if you were coming in and you said, I have a special enrollment period, to be enrolling. And now that's going to be very strictly regulated as well. I'm going to slowly cut this off in a little bit because I know I'm going over a lot of different examples, things that you may already be familiar with. But the last one that I'll point out, because it may be something that you think about from a sliding fee scale perspective. So one of the new things also in HR 1 is that certain Medicaid expansion adults will now have to pay out-of-pocket costs. So that means certain types of visits, so let's say non-emergency room visits, et cetera, certain types of lab tests, et cetera, things that before were covered by Medicaid are going to have a cost associated with it. The maximum will be $35. And then a max at 5% of family income. But this is, of course, another huge new addition to Medicaid rules that enrollees, but also families will need to pay attention to. In response, because of course, part of all these changes at the federal level have restricted dollars that are flowing down to the states. So over the next 10 years, we're going to see several billions of dollars be limited to states. We've seen them starting to already change what they're covering and what they're not covering. As an example, in Colorado has already limited the number of rides that members and enrollees can take. That's covered by Medicaid. Iowa has also changed the income eligibility threshold for certain types of pregnancy and postpartum enrollees. California has made a variety of changes as well, introducing premiums for non-citizen Medi-Cal enrollees. So we expect as well, including North Carolina, who just did 6% cuts to providers from the Medicaid program, things like this that are coming down the line. If as well, feel free to mention in the chat if those are things that you're paying attention to and nervous about, particularly from the provider cut side. I know with PPS rates things might be different, but if it's something that you're thinking about in terms of funding, I'd love to know as well. And now with the last roughly 15 minutes that we have, I just wanted to talk a little bit about why we care so much about the information that you saw upstream and how we think about it as an organization, as a TurboTax for Medicaid that serves healthcare organizations. All of those rules that you saw above, imagine you are a mother of two needing to stay on top of all of these changing rules. The rules change in 2023, 2024, 2025. There will be more to come in 2026 through 2028. So expecting a family to stay on top of these is like expecting everybody to be a tax expert, right? We do not expect that of patients. And then when I think about your organizations on the community health center side as well, that's a lot to stay on top of, including all of the day-to-day things that CHCs are already, FQHCs are already doing to serve patients. Putting paperwork on top of that is another burden. And so when I think about the work that we do, we know that one, patients really trust their community health partners when it comes to making their healthcare decisions. So given that FQHCs and CHCs and providers might have limited resources, how can we serve them and be a augment to the work that they do? Well, we do that by serving those organizations as a digital navigator. So being able to help folks navigate Medicaid, ACA, CHIP, et cetera, either at the point of care or at home. And we, of course, white label for organizations. And what we've seen in doing this work, so being that TurboTax for Medicaid, so that your organizations don't have to do it directly, but can rely on a partner, is that we've been able to reduce the amount of burden. So the number of people that were spending time on paperwork who are now going back to providing care or doing other types of local resource support, including housing, et cetera, for patients. And we've also seen being able to maintain a really high renewal rate for any patients that are using our product to be able to renew. So what does all of that mean? I kept using that terminology, TurboTax for Medicaid. Um, what are the types of features and functionalities that we extend support over so that we can help patients? Well, of course, there's enrollment and renewal, but ongoing actions. So, as I mentioned earlier, 6 month redetermination, work requirements, community engagement. So, there's a lot of follow up that patients and enrollees will have to do now to maintain and stay on top of their coverage. Of course, being able to connect with a live navigator is really important to us, is really important for patients and enrollees to have trust. So that's a big element of the work that we do. One of the things as well is, of course, knowing your ID and your plan details. So if that's your Medicaid ID number for you and the family, if you have a new managed care plan, or maybe different folks in the family have different managed care plans, being able to really clearly find that and take a look at that, helping you understand your coverage if you're a patient as well, what's covered, not covered, and then those transitions to marketplace. Now, given all those rules are there for special enrollment periods and requirements that patients and enrollees need to maintain, those are things that we can support on as well. In the last few minutes, I thought it would be exciting to show a little bit of the product experience. I'll see how much I can get through in that time. But if anybody has questions or thoughts on anything that we walk through, again, things that you're thinking about with HR1, things that you're thinking about with work requirements, would love to hear about any of that in the chat. So give me 1 second just to share a different screen. Alrighty, I think you're able to see this experience here. As I mentioned earlier, we really embrace that TurboTax for Medicaid mentality to make things simple and easy. So, to use an example of something that we walked through a little bit earlier in the slides, which was being both on site, so at the point of care or maybe at somebody's home, we're commonly available on, let's say, an iPad or as a part of discharge or packets that you may give patients when they're leaving to help folks see maybe you qualify for coverage, or maybe you lost coverage in the past, and you just want to see if you still qualify. We make it super simple and easy to go through this experience for you and your household. I'm going to switch into Spanish as well, so you're able to see that how we support a variety of different languages. We do about 8, but I'm going to switch back to English, just so one, I don't speak very good Spanish, so I'm going to go through in the English experience. We want folks to feel confident that even if they're not sure what they're supposed to be doing here, that there's always a live navigator, again, available for you. If you'll notice, a lot of this is in as simple as possible language. We try to make everything in 5th and 6th grade language so that folks are really easily able to go through and put in their scenario, or maybe you're helping out a patient and you want to be able to input some of this information as well. I'm just going to do a simple scenario of someone who maybe makes about $200 a week. But I also want to point out things that we see people make sometimes errors or miscalculations around when they're thinking about reporting their household's income. A lot of folks do not know that their unemployment benefit counts as income. Even Social Security, depending on the type of program, also counts as income. People sometimes forget some of their seasonal employment or cash pay. So all of those things are important to identify and provide. But this, what you're seeing here, is really just a screening experience to help somebody understand as quickly as possible if they may qualify for a government program. I'm also not sure if you noticed this, but we didn't ask anybody for their name. We didn't ask anybody for their social security number. We just asked for email or phone to be able to follow up after this in order to continue to engage folks. That level of privacy was really, really important because what we've seen is if you ask somebody for their name or that private information up front and you do not anonymize it, they are less likely to go through both checking eligibility and enrolling. So all of those types of decisions are all very, very intentional in how we've designed the experience to be as private and secure as possible for helping a consumer, helping a patient enrollee feel confident in going through the process. Um, Yes, I did. That's a great question, Kate. Yes, there are now a number of plans that are no longer sponsoring or supporting brokers and CACs in ways that they used to before. Also, the federal government cut navigator funding by 90% at the beginning of this year. So when we think about what are the resources available to the public, available to patients beyond the four walls of your clinic, there are fewer that might be available to them. So thinking about how your organization will be stepping up to support, whether it's with and training up folks to be experts or having resources like this available, all of that is is important and relevant for how they may be navigating their coverage experience with HR1. I went back in the eligibility experience to up the income level. The reason I did that is because, as many of you know on the call, there are many, many types of Medicaid and coverage programs. There are programs related to pregnancy that could qualify a person. So even though, let's say, this person's income went up, they're actually still eligible because now they're in a different income bracket. But if we say that they weren't pregnant, now you're seeing a totally different set of rules that could qualify this person based on the state that they're in, which is New York, for coverage. And a really interesting result that you're seeing here is because this person sits on the threshold now for a certain program in New York, which is called it's a BHP, it's called the Essential Plan. All of those different types of coverage programs we include in the product. So we're not just thinking about Medicaid, we're thinking about CHIP, we're thinking about all the different Medicaid variations. So Medicaid for tuberculosis, there's PACE programs, there's Medicare and Medicaid joint together. All of that we want consumers to be able to screen very easily for, and then go directly into an enrollment experience. So one of the other things that we care a lot about, and I know we're coming up on time, so I'm just going to jump really quickly into it, is we want to make this not having to point someone, hey, go to the state website or fill out all this paperwork and we'll see what happens. You can go directly into enrollment, directly into renewal within Fortuna. And we can help you in a lot of different ways. We have an AI income experience where somebody can describe even the most complex, convoluted case, and we actually convert it into the format that's required in the state that you're in. So there's a lot of different permutations for if you're weekly, how you might multiply and calculate your income in the state of Connecticut, let's say, versus the state of West Virginia is different from how you calculate biweekly. All of those rules we've layered in here from our work over the last couple of years supporting enrollees and submitting applications. Other things that are really relevant that today you may not be helping, or you may not know that an enrollee can qualify for, is there's a lot of different expenses, whether it's rent or medical bills, et cetera, that you can also use as an enrollee to qualify for Medicaid or other government programs. So we make it super simple for, even if you don't know all of that, to be able to be and become an expert. And as I mentioned, of course, too, when you think about both Medicare and Medicaid, those are important things to highlight as well. I know we're coming up on time, and I wanted to make sure we left room for questions. But maybe the last thing that I will switch over into is talking a little bit about renewal, because of course, a lot of the new rules are related to increasing recertification and work requirements. So those are also things we make sure we let consumers know we can help them with. One of the most interesting things that we've learned is that about 40% of people that come through are interested in what their renewal date is. And that was very interesting to us. That many people are unsure when they're actually supposed to renew. So, different things like that are all data that we think is important for an organization to know, that this is what people are thinking about. This is what your patients are nervous about. Maybe they don't just need to renew, but they want to check when they have to take and make those actions. And if they have a new situation, how to think about taking those and making those actions. So I'll stop sharing. There's, of course, plenty to show there, but some last things to walk through is just some of the nuances of um, things that we have seen states and counties um, require of consumers and enrollees and where they've struggled. So if you are in one of the 26 states that has counties, local counties involved in Medicaid enrollment and Medicaid renewal, these are things that you may more commonly see than a state that's more centralized. So, one example is, of course, proof of income issues because maybe somebody didn't check all of their documents. Others, sometimes the state or the county will issue a request for no income. And so, how you're asking an enrollee, how do I prove to you that I have no income? All of those things are things that you can provide in an affidavit or a signed document. Really important to know how you can support folks with that. And maybe the last thing, just because I think it's a really big challenge, and and it's something that your org should be on top of. Sometimes we see that there's a disconnect between the state's data and the enrollees' data on the name of the organization that they work at. And to give you an example, is McDonald's is a franchise. So let's say the enrollee or your patient says, I work at McDonald's, but the state says, actually, you work at 123 Bob Frank LLC. And it's still the McDonald's, but one is the organization's name and one is the name that the patient slash the enrollee recognizes. So all of these are things that we know are going to be challenges, things that if your organization is thinking about staying on top of, we'd love to chat. We believe that this is going to be one of the most important periods for your org to make sure that patients know and can act with clarity and confidence around their coverage and know that they can come to you as their trusted organization. So that's it from me. Thank you so much for the time. If there's any questions that folks have, feel free to drop it in the chat. Or otherwise, you can always reach me at Nikita at Fortuna Health if you ever want to chat about Medicaid, CHIP, and government programs. Perfect. Oh, I'm seeing a lot more questions now. I was in the wrong tab. I apologize about that. Oh, there's a lot of different questions around, does this work across all states? Mario, it works in the states that we're operating in, which today is 10 states. We hope to be in all 50 over the next couple of years. And then Tiffany, the question on, do we white label? Yes, we do. We white label and we co-brand with organizations for both enrollment and renewal purposes. The reason that we do that is actually not just for the sake of it, but because we've seen that enrollees and patients take action, and they're more likely to take action when they see it's coming from a partner that they trust. So sometimes folks, when they see something from from the state, they're sometimes a little bit more skittish than if they see something from the provider that they know and trust. One or another question is, how do you determine a patient's renewal date? That's a great question. So in the 10 states that we operate in, hopefully going on all 56 states and territories, we actually have connectivity into state systems to be able to pull that. We also take on certain licenses as an org auth rep, or sometimes a navigator, or sometimes an agent, to be able to, again, go into state systems and access that information. And health plans provide it as well. It's sometimes in that 834 file for what their end of coverage is. One interesting fun fact is that end of coverage dates actually move around in a lot of states, depending on whether a family also has SNAP, because the SNAP date actually sits upstream and is the core date. So if somebody, let's say, has to take an action in November for Medicaid, but their SNAP is up for renewal in December, that actually means that the person's renewal date will be December because it extends it out. So all of those interesting facts a lot of folks don't know, but when you look deeply at the rules of each state and also how the state systems work, those are different calculations that we'll see in how dates move around. And Naeem, no problem. I also know we have come up on time, so I'm happy to provide this deck as well if that's interesting or relevant for folks to take a look at. Okay, I see one person asking them. We definitely will, Tiffany and Constance. Awesome. Wonderful. Thank you all so much for the time today and your patience.